Every 66 seconds, another person in this country is told they have dementia. Somewhere in a percentage of those cases, the real cause was never sitting quietly in their genes or waiting patiently in their age. It was sitting in a bottle on the bathroom shelf, something a doctor prescribed years ago and nobody ever thought to question again. There is a specific, well-documented category of everyday medications, some of them sold without a prescription at all, that research has repeatedly connected to a faster path toward memory loss and dementia. Not exotic drugs. Not anything requiring a specialist. Medications sitting in pharmacies by the millions, taken every single night by people who have no idea what they are actually doing to the brain over time. Today we are counting down 9 of them, from the ones that quietly get overlooked to the one that may be doing more damage than any single medication on this entire list, because it is not a medication at all. Stay with me until the end, because the final entry is not one specific pill, and once you understand what it actually is, you will probably want to go check your own medicine cabinet tonight. Before we start, one thing needs to be completely clear. Nothing in this video is a reason to stop any medication on your own. Every single drug on this list exists because it treats something real. What this video gives you is the same information researchers already have, so you can bring the right questions to your doctor instead of finding this out the hard way, years later, after damage has already been done. It helps to understand, before the countdown begins, why this particular category of risk manages to hide in plain sight for so many people. A typical appointment where one of these medications gets prescribed rarely lasts more than 15 minutes, and in that window, a doctor has to cover the diagnosis, the treatment plan, and the prescription itself, with very little time left over to explain a mechanism as detailed as acetylcholine blocking or cumulative burden. Multiply that across years of refills, several different specialists who rarely communicate directly with one another, and the addition of over-the-counter products nobody thinks to mention at all, and you get exactly the kind of quiet, invisible accumulation this video is built to expose. Let's start counting down. Number 9, and do not let the low position fool you, because this one is sitting in more medicine cabinets than almost anything else on this list. Diphenhydramine, the active ingredient in Benadryl, the small pink pill people reach for to fall asleep, calm an allergy, or take the edge off a cold. It costs almost nothing, sits on an open shelf with no prescription required, and because of that, most people assume it must be gentle. Inside the brain, it is doing something considerably more aggressive than most people realize. Diphenhydramine belongs to a class of drugs called anticholinergics, meaning it blocks a brain chemical called acetylcholine, the exact messenger your brain relies on to lay down new memories and stay mentally sharp. As the brain ages, it naturally produces less acetylcholine to begin with, which means a drug blocking what little remains lands considerably harder on a 70-year-old brain than a 30-year-old one. A large study published in JAMA Internal Medicine in 2015, tracking thousands of older adults over roughly a decade, found that people with the highest cumulative use of strong anticholinergic drugs, diphenhydramine included, had a risk of developing dementia that was roughly 50% higher than those who rarely or never use them. Here is what to actually do with that. Check the label on anything you take for sleep or allergies, because a lot of products marketed as nighttime, PM, or allergy relief are simply diphenhydramine, wearing a different name on the box. Newer antihistamines like loratadine do not cross into the brain the same way and are considered a safer long-term option for allergies specifically. Never stop a sleep aid abruptly on your own. Bring it to your doctor first. It is worth pointing out how many products actually contain this same ingredient without saying so plainly on the front of the box. Nighttime versions of common pain relievers, many over-the-counter sleep aids marketed under entirely different brand names, and a range of cold and flu combination products all frequently rely on diphenhydramine as their active sedating ingredient. Reading the actual ingredients list, not just the marketing name on the front, is the single most useful habit anyone can build here, since it is entirely possible to be taking this exact drug nightly for years under several different product names without ever realizing it is the same compound each time. Number 8 is a medication your stomach genuinely appreciates and your brain may be quietly paying for. Proton pump inhibitors, the big names being omeprazole, sold as Prilosec, and esomeprazole, sold as Nexium. These shut down acid production in the stomach and get handed out constantly for heartburn and reflux. People frequently stay on them for years, sometimes decades, because the moment they stop, symptoms come roaring back, which makes the medication feel indispensable. Here is what rarely gets explained at the pharmacy counter. Stomach acid is required to properly absorb certain nutrients from food, vitamin B12 chief among them, a nutrient essential for healthy nerve and brain function. Suppress that acid long enough and B12 levels can quietly decline, along with magnesium and calcium, both of which neurons depend on to fire and signal properly. A large study published in JAMA Neurology in 2016, drawing on German health insurance data covering more than 70,000 adults over age 75, found that regular PPI users carried a risk of dementia roughly 40% higher than non-users. Some research has also found PPIs associated with higher levels of amyloid beta, the protein that accumulates in Alzheimer's disease, though this particular mechanism remains an active area of study rather than settled fact. If you take a PPI daily, that is worth a direct conversation with your doctor about whether you can taper toward a gentler option, such as an H2 blocker like famotidine, or address symptoms through diet and timing changes, using the lowest effective dose for the shortest reasonable duration rather than staying on it indefinitely out of habit. It is worth being fair to this particular entry, since PPIs remain some of the most useful medications available for genuine diagnosed acid reflux and ulcer conditions, and stopping one abruptly can cause a rebound surge in acid production that makes symptoms temporarily worse than before treatment even began. The goal here is not fear, it is awareness that a medication started for a short-term flare-up sometimes quietly continues for a decade, simply because nobody ever revisited whether it was still needed at the same dose. Number 7 is prescribed for something most people would rather not discuss out loud. Bladder control medications, and the one to know by name is oxybutynin, sold as Ditropan, given to people managing overactive bladder and that sudden, urgent need to reach a bathroom. The relief this provides is genuinely real. So is the acetylcholine blocking mechanism running underneath it, the same one covered in the first entry, except oxybutynin crosses into the brain particularly easily. Research examining long-term anticholinergic use, oxybutynin specifically included, has found dementia risk climbing by roughly the same magnitude as diphenhydramine, somewhere in the range of a 40 to 50% increase with sustained use over a year or more. What troubles researchers most about this particular entry is how rarely patients are ever warned. They are told a pill will calm their bladder. Nobody mentions it might be dimming their memory at the same time, and the resulting fog gets quietly blamed on getting older rather than traced back to the prescription. If you take oxybutynin and have noticed your memory slipping, that deserves real attention, because you do not have to choose between bladder control and cognitive health. Newer medications like mirabegron work through a completely different pathway that does not touch acetylcholine at all, and offer many older adults similar relief with considerably less risk to thinking. Worth raising at your next appointment. Number 6 might be the most surprising entry on this entire list, because it is one of the most prescribed medications on the planet. Statins, including simvastatin and atorvastatin, taken daily by an enormous share of adults over 60 specifically to lower cholesterol and reduce heart attack and stroke risk. Let's be clear from the outset, this is not a case against statins. They save lives, and this entry deserves more careful, honest framing than most videos give it. Early case reports in the 2000s raised concern about statins and memory, serious enough that the FDA added a cognitive side effect warning to the label. But the much larger body of research that followed has told a considerably more reassuring story. Several sizable long-term studies have found no consistent link between statin use and increased dementia risk, and some research has actually found modestly lower dementia risk among statin users, potentially tied to the anti-inflammatory and vascular benefits statins provide. This entry earns its place on the list specifically because it illustrates how quickly an early warning label can outlive the science that eventually moved past it. If you are on a statin and noticing cognitive changes, it is absolutely worth mentioning to your doctor, since individual reactions do vary, and some patients report improvement after switching to a statin that crosses less readily into brain tissue, like pravastatin. But this is not a medication to fear or stop based on outdated concern alone. Quick pause here, because if this is helping connect some dots for you or someone you love, this is exactly the point in the video worth pausing to think about which of these 9 you or a parent might currently be taking. Keep that list running in your head as we move through the rest of it. Number 5 is benzodiazepines, medications like lorazepam, sold as Ativan, diazepam, sold as Valium, and alprazolam, sold as Xanax, among the most commonly prescribed drugs in the country for anxiety and sleep. They work by boosting GABA, the brain's natural calming signal. In the short term, for occasional use, they are generally considered reasonably safe. The concerned researchers have raised centers specifically on long-term, regular use. A study published in the BMJ in 2014, following thousands of older adults, found that those using benzodiazepines for extended periods carried a meaningfully higher risk of an eventual Alzheimer's diagnosis, with longer-acting versions like diazepam appearing more concerning than shorter-acting ones, since they linger longer in the body and accumulate in fatty tissue, brain tissue included. It is worth being direct about something here, because this remains a genuinely debated area of research. Some scientists argue the association may partly reflect reverse causation, meaning early undiagnosed dementia can itself cause the anxiety and sleep disruption that leads a doctor to prescribe a benzodiazepine in the first place, rather than the drug purely causing the decline. Both explanations are actively studied, and the honest answer is that elements of both are likely true. What matters practically is this. If you have been on a benzodiazepine for more than a few weeks, never stop suddenly, since doing so can be genuinely dangerous. Work with your doctor to taper gradually, and ask about gentler alternatives like buspirone for anxiety, or specialized non-drug therapy approaches for chronic insomnia. One detail worth adding here, since it applies specifically to this entry more than most others on the list. Benzodiazepines carry a genuine risk of physical dependence with regular use, meaning the withdrawal process itself needs to be handled carefully and gradually under medical supervision, sometimes over a period of weeks or months rather than days. This is not a reason to avoid ever addressing long-term use. It is a reason to treat the tapering process itself as seriously as the original prescription. Number 4 is a single medication prescribed for 3 completely different problems, which is exactly why it became so widespread. Amitriptyline, sold as Elavil, an older antidepressant still commonly used today for nerve pain, sleep difficulty, and migraine prevention. That versatility made it look like a medication that could do everything, but underneath, it is one of the more powerful anticholinergic drugs still in common use, strongly blocking the same acetylcholine pathway covered throughout this entire list. The same JAMA internal medicine study referenced earlier, the one that found a roughly 50% increased dementia risk with high cumulative anticholinergic exposure, specifically included amitriptyline among the medications contributing most heavily to that total burden. It does not require a high dose either. A small nightly dose taken consistently over years for something as ordinary as nerve pain can quietly erode cognitive function with no obvious warning sign until real ground has already been lost. If you or someone you love takes amitriptyline regularly, that is worth a direct conversation soon. For nerve pain, options like duloxetine or gabapentin can offer similar relief without the same anticholinergic weight. For sleep, low-dose doxepin carries a considerably gentler profile on this specific pathway. For mood, newer antidepressants like sertraline are generally considered safer for long-term brain health. Number 3 is the one I told you to watch for, because it is prescribed to millions of people for something that sounds completely harmless. Paroxetine, sold as Paxil, one of the most widely prescribed SSRIs, a family of antidepressants generally considered gentler than older psychiatric medications. Here is the detail that rarely comes up. Paroxetine is the one commonly prescribed SSRI that carries meaningful anticholinergic activity of its own, setting it apart from close relatives like sertraline and escitalopram, and placing it on the same acetylcholine blocking pathway running through nearly every entry on this list. Research examining SSRIs in older adults has found paroxetine users showing measurably greater declines in short-term memory and word recall compared to those on other SSRIs within roughly the first year of consistent use. Because of this, the American Geriatric Society has specifically flagged paroxetine on what is known as the Beers list, a formal catalog of medications considered potentially inappropriate for older adults, precisely for this reason. If you currently take paroxetine, it is worth asking your doctor directly about switching to sertraline or escitalopram, both considered gentler options with the same underlying benefit for mood and anxiety, minus this particular cognitive concern. Number 2 is prescribed so quietly that many people taking it do not fully realize what category of drug it actually belongs to. Antipsychotic medications, including quetiapine, sold as Seroquel, risperidone, and olanzapine. These were developed and approved for serious conditions like schizophrenia and bipolar disorder. Today, they are frequently prescribed off-label to older adults for something entirely different: sleep problems, restlessness, or the agitation that sometimes accompanies dementia itself. This is genuinely the one entry on this list where regulators have taken the strongest, clearest action. Antipsychotics carry an official boxed warning stating that use in older adults with dementia-related psychosis is associated with increased risk of death, and research tracking cognitive outcomes has found faster decline associated with antipsychotic use in exactly this population, the same population these drugs often end up prescribed to for behavioral symptoms. If you or someone you love is on one of these medications, the first question worth asking the prescribing doctor is simple. Why was this started, and is it still necessary, or is it being used mainly for convenience? Many behavioral symptoms in dementia can improve through consistent routines, treating underlying pain, and reducing overstimulation, before medication becomes necessary at all. When medication genuinely is required, the lowest effective dose for the shortest duration meaningfully reduces harm. And now, number 1, and this is not a single medication at all, which is exactly why it may be the biggest hidden driver behind nearly every story in this entire countdown. Anticholinergic burden. It is the danger almost nobody explains clearly, and it may be one of the most preventable contributors to medication-related memory loss that exists. You are probably expecting one final villain, one worst pill to close out the list. The reality is more subtle, and in some ways more important than any single entry so far. The greatest danger typically comes from the slow, quiet accumulation of several anticholinergic medications taken together, while nobody ever adds up the total. Picture a common, entirely plausible scenario. Someone takes diphenhydramine nightly for sleep, oxybutynin daily for their bladder, and amitriptyline for nerve pain. 3 completely different prescriptions from 3 different specialists who have likely never spoken to one another. Individually, each medication might produce a fairly small, barely noticeable effect. Combined, those effects stack, and the total burden on the brain climbs considerably faster than any single prescription would suggest on its own. A large study published in Age and Aging, tracking 250,000 older adults, found that those in the highest category of combined anticholinergic burden faced a risk of dementia more than double that of those with minimal exposure. And the overwhelming majority had no idea they were even taking anticholinergic medications in the first place, because nobody had ever explained the concept to them or added up what they were actually taking across every doctor involved in their care. Here is the genuinely hopeful part, and it is the entire reason this topic is worth 40 minutes of anyone's attention. Medication-related cognitive decline, when caught early, is frequently reversible. Reduce the burden, and many people regain real clarity and memory within weeks or months, because the brain remains considerably more resilient than most people assume, as long as the source of the strain is actually identified and removed. This does not require a miracle. It requires a genuine medication review, sitting down with a doctor or pharmacist, listing every prescription, every over-the-counter product, and every supplement currently being taken, and specifically asking about total anticholinergic burden. Pharmacists increasingly have simple scoring tools designed exactly for this purpose, and asking for that review is a completely reasonable, increasingly common request rather than an unusual one. This is really the thread connecting all 9 entries on this list. It is rarely one dramatic villain acting alone. It is the quiet, compounding effect of ordinary medications, each individually reasonable, each prescribed by a well-meaning doctor for a real problem, gradually stacking on top of one another in a way that no single provider was positioned to see. A pharmacist reviewing a complete medication list all at once in one sitting remains one of the most underused tools in the entire healthcare system for catching exactly this kind of accumulation before it becomes a serious, harder-to-reverse problem. If any of this matched something you or someone you love is currently taking, this is worth bringing up directly at the next appointment, not stopping anything today on your own. A 5-minute conversation about a bladder medication, a nightly antihistamine, or an old prescription nobody has revisited in years can genuinely change the trajectory of someone's cognitive health going forward. The single most useful thing you can do after watching this is not panic, it is preparation. Write down every medication, every dose, and every over-the-counter product currently in the house, and bring that list, complete, to the next appointment, rather than trying to recall it from memory in the room. Tell me in the comments how many of these 9 you or someone you love currently takes, and whether this is a conversation you are planning to have this week. If this gave you something worth acting on, hit subscribe, because there is a lot more research-backed insight like this coming, and you will not want to miss it.